So look back at atherosclerosis. So it's an inflammatory, immunological, polygenic, and multifactorial disease. Okay, includes lipid deposition, fibrosis, calcification, plaque formation, and it's mostly found in the intima of large and medium vessels. See here is understanding that the intima is all up throughout here. Meanwhile, the media layer, where it's supposed to be, right on top of, is back down here. So we're looking at significant obstructions, even more significant, almost 100%. You can see that there's already some plaquing going on here. If you see real closely, there's a nice clot down the middle of the artery, in the middle of the heart there. There's a nice remnants of some clots in here. This is looking at a ventricular aneurysm, so you see that there's nice meat and muscle fiber around here, and then it really thins out here. You'll see this is a complication, especially in the units, and myocardial rupture, pericardial tamponade, etc. And again, here's just another take a look through about 100% obstruction. So if we look at ischemic heart disease or atherosclerotic heart disease, risk factors are being a male up until about the age of about 45 or menopause, 45, 50. Males' estrogen levels are pretty much the same throughout life. Females, their estrogen level takes a hit right as you hit menopause. Estrogen appears to be cardioprotectant because females' rates of heart disease start to go on the ascent and overcome males right after menopause. Cigarettes, family history, high blood pressure, diabetes, obesity, inactivity, dyslipidemia. So angina, pectoris with pain in the chest, secondary to ischemia. Again, myocardial oxygen demand has overcome myocardial oxygen availability. Nausea, sweating, feeling of impending doom. Referral pattern is just to remember and keep in mind those classic patterns of jaw pain, neck pain, just scapular pain, left arm, shoulder issues, etc. Feeling lightheaded. So angina gets divided again into some subcategories. Stable angina is exacerbated by activity, relieved by rest, typically predictable. Patients know that they can walk from their bedroom to their bathroom, but they can't walk up more than 2 flights of stairs, etc. Excuse me. Patients are often prescribed nitro, sublingual, sprays, the tablets, whatever they got. Prinzmetal's angina is vasospasm at rest. You can see that in cocaine abuse or drug abuse, where a person has an MI on autopsy, or if they have an MI, they present on EKG with enzymes. You take a look at their angioplast or their angiogram, and it's fairly clean. And that's just because that they've gone under significant vasospasm. An unstable angina is a changing pattern or a new presentation. So, a person who predictably had a history of angina but is now only able to walk up a couple of stairs, or is having some more pain during restful activities or less activity. That's unstable angina, and that needs to be worked up anew. So we have a fairly recent term called acute coronary syndromes, or ACS, and that has a whole spectrum from unstable angina to actual death of heart tissue, the myocardial infarct. And that's divided up into STEMIs or NSTEMIs, ST segment elevated myocardial ischemia, or non-ST segment elevated myocardial ischemia. Clinically, these two are related distinctly in that STEMIs usually are categorized and triaged into activation of the cardiac cath lab and thrombolysis and going upstairs. NSTEMIs don't seem to respond too well to that. NSTEMIs don't seem to have the same effect, resulting in and responding to cardiac catheterization and thrombolysis, etc. So remember that these patients rarely complain of pain. They complain of pressure, uneasiness, etc. There's your ST segment in here. So we're looking for elevation. EKG electrode placement, which goes from where 12 lead used to be standard and evolved into the standard only a few years ago. We're moving now into 15 lead, 18 lead, 24 lead to get a view of the heart from 360 degrees as much as possible. A couple of things to learn. About 20% of patients will die before they reach a hospital from sudden cardiac arrest. About 1/3 of the MIs are silent or asymptomatic and discovered years later at a physical exam. And that the elderly, women, those of people who have diabetes, those of African descent, present atypically. And that's a huge percent of the population. We focus on things like women usually present with back problems like scapula pain, some vague neck issues, etc. People with diabetes, just like they have trouble feeling their fingers and toes, they also have neuropathy in the cardiac nerves, and so they very similarly don't get these cardiac chest presentations. So they'll present with diaphoresis and just not feeling right. What they're actually having is an MI. So the test, we look at an EKG, you look at a chest X-ray. One of the things you're looking for in the chest X-ray is not to diagnose the MI, but to look for other things that are causing chest pain or other things that are causing that symptomatology, and other things that are going to contraindicate the recommended therapy. So if you see a huge widened mediastinum, or you see a pneumo, you see fractures, etc., that's going to alter your care plan, alter your assessment and diagnosis. So your mainstays are usually looking at EKG to diagnose the ST segments, and for blood, looking at your CK, your CPK-MB, troponin T, and troponin I, and your subfractions. Please remember that EKG results are commonly negative for a little while, and blood may be negative for a little while. So you need to look at your clinical suspicion, especially if you're alone in independent practice and you have a 53-year-old woman who's come in saying that her shoulder's feeling achy all day, but she did some gardening last night, and maybe she slept wrong, etc., etc. Just doing an in-office EKG that comes up negative does not necessarily disqualify her from being an ACS patient who might need to go to the ER emergently. So looking at MI treatments, things like rest, oxygen, IV access, EKG monitoring, morphine, beta blockers, decision for thrombolytics, catheterization, bypass. A couple of slides just giving you an idea about coronary circulation, the difference between where the obstruction is and what the symptomatology and what the side effects, or actually, not better term than side effects, complications are going to be. You have the right coronary artery and the left coronary artery. Both of them come off of the ascending aorta just a bit right after the aortic valve closes. So the right coronary artery supplies blood to the right atrium and right ventricle, okay, which also includes much of the conduction system and the inferior and posterior left ventricle. So it supplies blood to the SA node in about 55% of the population, just more than half. And it supplies blood to the AV node in about 90% of the population. So occlusion of the right coronary artery leads to inferior and posterior wall MIs and bradyarrhythmias and bradycardias, as seen as most common complications. If you look at the left coronary artery, that's going to supply pretty much the left atrium and the left ventricle, and what you can, as well as the main part of the septum and the anterior wall. So if you try and take a look at who's more likely to have a bradyarrhythmia, well, it would be the person who's coming back with a right coronary artery infarct. Who's more likely to develop pump failure? More likely to develop pump failure. Probably be a left ventricular or left coronary artery obstruction, because that's where really most of your heart muscle is going to come from. If we move away from atherosclerosis and look at congenital anomalies, so what we look at here is tetralogy of Fallot, which has four main factors. A septal defect, right, which is a hole in the septum. If the septum's keeping the right heart and the left heart separated, and that it has a hole in it, we call that a septal defect, and you get mixing of oxygenated and unoxygenated blood. Right ventricular obstruction, okay, so you get stenosis. An overriding aorta, which means the aorta, instead of taking blood directly from the left ventricle, due to all the problems in the heart, is taking, especially the septal defect, is taking blood from both the left and right ventricles, which means you're going to get mixed blood again going into the aorta. And right ventricular hypertrophy. Right ventricular hypertrophy is going to be a result of the right ventricular outflow obstruction. If we look at septal defects, again, just what we saw earlier. Very, very common reason for a visit to a pediatric cardiologist is either an atrial or a ventricular septal defect. A PDA is a patent ductus arteriosus. Patent ductus arteriosum is a finding that ductus arteriosum is an opening between the arch of the aorta and the pulmonary trunk in utero, because the baby doesn't need to breathe. Mommy's breathing for the baby, so there's really no need to send blood off to the lungs to be oxygenated. It just goes straight out into the aorta. And that usually closes shortly after birth, but sometimes in preemies and sometimes in full term, that blood vessel doesn't close, so it's called patent. So if you think about a patent airway being an open airway, that's a patent ductus arteriosum, so that's an open ductus arteriosum. So now you have a baby that's term and that's breathing, only its blood is not really still going off to the lungs, so you're going to get some oxygen mix etc. And this can usually be closed by an injection of indocin and domethicin. Sometimes they might have to go in and surgically repair it. Coarctation of the aorta is sort of a pinching of the aorta up here. So what you would expect is elevated blood pressure in the arms and decreased blood pressure in the legs.